talk about taking care of these patients here at Aurora on France. Talk about the standing orders that the hospitalists will send to you. And it's specifically for heart failure care. And then the education book and a stoplight. So in your folder, you have this stoplight form, and you'll become very familiar with it when you take care of your patients. And then this is the education booklet that patients will come over from the hospital with this, but if they don't, then you can give them one of these. Taking care of heart failure really is a coordination of care for the hospital providers, the TCU caregivers, the core clinic providers, the people at home, so the caregivers for the patient themselves, the home health nurse, the pharmacist. It really takes a coordination of care. We work very closely with the primary care doctor, the nephrologist, the pulmonologist, because when we coordinate care together, the patients really do well or better. So Dr. Ernst showed you this vicious cycle patients are in. So if you have seen that they have had multiple readmissions, then you know that they're in this vicious cycle. And we need to help them get out of this vicious cycle. So after they come to the emergency room, receive IV diuretics, are taken care of by the doctors in the hospital, they have a 2-gram sodium diet, they feel better, their symptoms are better, but they do go home if they're not educated, and they'll eat their corn dog again, right? So all the good care, it helps, but if you can't change something, they'll continue in this vicious cycle. So some patients look for a corn dog that's less salt, or if they learn how much milligrams of sodium is in a corn dog, then maybe they'll change their breakfast to something healthier instead of a breakfast out of a box. So I always talk to them about, let's find foods that you like. So we created this core clinic over 10 years ago, and we see people, educate them, and watch some of them closely. And by seeing them closely and caring for them, it really helps them stay out of the hospital and improves their quality of life. And we decided not to call it a heart failure clinic because we wanted patients to come to it. So why does this model work? We have cardiologists that specialize in heart failure care. We have nurse practitioners and physician assistants that specialize in this care. We have great core nurses that we couldn't do it without them, that really get to know the patients and talk to them a lot about their lifestyle and helping them take care of themselves, or talk to the family about taking care of the patient. We give the patient a direct phone number to the core clinic. They don't have to call the main number and punch this number, punch that number. And so they know exactly that they can call this number and talk to Tiffany or Michaela or Ann, our other nurse, which people who are old, they like that. They like to call someone that they know. We have that telemanagement program. About 50 or so patients are enrolled in the telemanagement, not all patients. So we enroll the patients that we think we need to watch on a daily basis. We help them get on medicines that are life-saving medicines, not just the diuretic, and not just a little dose. We try to work every time we see them and inch up the good medicines. And education, we try to educate them. Why should they weigh themselves? What are their symptoms of congestive heart failure? That type of thing. And then a lot of the patients, it's about management. So Dr. Ernst talked about the symptoms, they ebb and flow. And so at times they may need assistance in managing their heart failure. So we do that by talking to them on the phone if we saw them recently, or we bring them in for a visit and adjust their medications, or we give them IV Lasix as an outpatient, instead of it getting bad where they end up going in the hospital. So our goal is to improve their quality of life because they're not having fun being readmitted, decrease readmissions, and our goal is to work with you on taking care of these patients. So we created an order set that the hospitalists have agreed to. They're the ones who are signing these orders over to you in the TCU, and they're standard orders. They're about CHF care, and I'm going to go through a few of them, so when you see these standing orders, you'll recognize them. So the first one is about patient self-management, and you'll have to assess how much self-management the patient can do once they come over here. Amy Peterson, your nursing manager, I don't know if that's, the consultant. She has really worked hard setting up things here for everyone to start. So she has worked it out where there's going to be a scale in the room for the patients with heart failure. I don't know if it's every patient, but I know for the patients who have congestive heart failure, the scale will be in their room. And then we're asking for the weight chart to be posted in the room, and the stoplight form, and in the orders is a daily weight, and we're asking the patient to record it, just like they would at home. So of course in the first couple days they may be not able to do it because they're just too tired, but our goal is that they would record it so that when they leave here, they'll be getting up in the morning, going to the bathroom, weighing themselves and recording it. So the stoplight form, if you look at it, that's in your folder. It's devised as the green is they're feeling good. The yellow is they have some symptoms or they're developing symptoms, and the red is not good. So before they came to see you, they probably were in the red zone, otherwise they wouldn't have ended up in the emergency room. And by the time they're coming to you, they may still be a little bit in the yellow zone, but hopefully by the time they leave here, they'll be in the green zone. So we're asking you to review this stoplight form with them every day. So as they get on the scale, weigh themselves, you review this little sheet, and you ask them to ask themselves, is my weight up? Do I have more swelling? Do I have trouble breathing? How did I sleep last night? And then you look in the boxes here on where their symptoms match and teach them that and encourage them to put this on the refrigerator at home. Because if they can identify their symptoms are in the yellow, then we want to give them the education of calling their doctor if they're in the yellow zone. So a daily routine here will be to weigh them and to review the stoplight form and review who they're going to call. So you'll ask them, who will they call? Well, some of them don't even know their primary doctor. Some of them have never even been to Core Clinic. So if they're enrolling in Core Clinic, which many of them, their first enrollment is after a hospitalization, so they don't even know what Core means. So by saying to them, well, are you going to call the Core Clinic? Well, they don't even know what that is yet. So it may be just their primary doctor first. And it would be nice if everyone had a primary doctor. And so maybe when you find out they say, I don't have a primary doctor, then maybe that's something the social worker can help them with. But they need to have someone to call if they develop these symptoms. After they are enrolled in the Core Clinic, we'll give them the Core nurse's direct phone number. Then they'll learn when you're in this yellow zone, you can call the Core nurse. Does that make sense? Mm-hmm. So back on the standing orders, the next step is the nursing care management, admission weight, recording weight, and then the education booklet. So this education booklet was developed about 10 years ago, or more than that. And it was really a team of people who created it, nurses at the university, at Southdale, Ridges, and we all used the same book. It was a huge feat that all of us agreed on one book. And it's edited every year. New ideas are in here. And so we developed this script for nurses that if you don't really know about the book, you can actually follow along on this script that says, well, if you want to give a medicine, go to page 9. If you want to talk about diet, you can kind of review this with them. If they've been admitted and they really need more education, they really need more help, you can explain what the Core Clinic is, that we work with their primary doctor. It's not instead of the primary doctor. If they have a cardiologist, we work with the cardiologist. It's a team effort. And you can show them the Core brochure and say, this is available to you. So that is the education booklet.
So Chris, not to interrupt, but all of the Core patients, when they're referred, will get one of these folders, or the brochure and the booklet, or no?
Well, in the hospital, if they have a diagnosis of congestive heart failure, they will get that booklet.
Okay.
We also have it all ordered into our patient education board, so if they don't have that, we have all of this stuff.
Got it.
Okay, great. But it's important to know that if they're labeled as a new Core patient, many of them don't know what that is yet.
Okay.
So the next section is nursing care management. These are reasons to call your provider here, your physician who will be rounding here, or your nurse practitioner. Heart rate less than 50, blood pressure less than 90, if their weight is up. So what we have found is the weight is done every day, but yesterday's weight isn't compared to today's. So if your nursing assistant is weighing your patient, I don't really know how that's going to be done, but you as a nurse or as a nursing assistant, look at yesterday's or look at the admission weight and see if it's different. If it's 10 pounds down, maybe they still had 10 pounds of fluid to lose, and then now maybe they're in the green zone. If they came in and their weight is 5 pounds up, they're not heading in the right direction. So the key is to notify the provider. So if your provider just saw the patient yesterday and is not coming for another week or in a couple days, your opportunity is to call that provider today, because you will prevent a readmission. Signs and symptoms of congestive heart failure, it's on one of the pages in the booklet. And when you review this stoplight form with the patient, ask them what their symptoms were when they went to the hospital, because most of them remember it. So you can say to them, if you develop these symptoms again, you need to notify someone. The other important team members at the TCU here are your dietitians. And I actually met 2 of the chefs. So they are motivated to create a low sodium diet for your patients. Many TCUs cannot offer that. They're like 3,000 to 5,000 milligram sodium diet, but the guidelines for heart failure is about 2,000 milligrams of sodium in a day. So the dietitian, the chefs, they're all motivated to offer this for the patient. Cardiac rehab, I think we'll be seeing the patient here. At least they're going to try to enroll the patients in cardiac rehab. There's certain guidelines. If they have systolic heart failure and they're Medicare patient, it is paid for. If they have a preserved, now that you know all this, if they have preserved ejection fraction, then cardiac rehab does not pay for it. But the WELL program, which is a phase 3 cardiac rehab, is available to them. And there is a cost, it's like $40 a month. But sometimes I will say to the patient, you could do the WELL program maybe for a month or 2, and then they'll give you guidelines for your YMCA that they possibly have silver sneakers or something, because it's nice to get guidance from the cardiac rehab folks. There's some other orders on there, but there's the discharging orders. We like to see the patient after their stay here 3 to 5 days, because most readmissions are within 7 days. And Tiffany and the core nurses can help you get that appointment. Social worker will evaluate them for home health. They will make their appointment with the primary care doctor. So I think your opportunity is recognizing heart failure. You're going to be with the patient. So if you see that they're more short of breath, if you see that they're changing from the green zone to the yellow zone, your opportunity is to notice that their weight's going up, they're becoming symptomatic, they have more swelling in their feet, and notify the provider. And early initiation of treatment, you can reverse that then. And then close follow-up is key. So causes of readmission, you saw this already. What's interesting about the medicine noncompliance that we're finding more and more is that there are the people who don't take their medicine on days they want to go out and about, and you can understand why. We try to encourage them to take it when they come home then at 2 o'clock or whatever, instead of omitting it completely. But part of that medicine noncompliance is they don't have the cognitive ability to set up their medicines or to remember to take their medicines. So you have an opportunity that when you're giving medications to patients, you can ask them, do you set up your medicines? Do you have someone to help you? There are services out there like Lund's Pharmacy that actually could set them up. I know Walgreens too, where they can set it up for a month and pay $15 a month to have someone else set it up. I mean, home health addresses that a little bit, but there are options for people who can't set up their own medicines because home health is only with them for a short time because you have to be homebound to receive home health. So then after home health sees them for a month, they need options of who can help them set up their medicines. So just to review, assessing the patient, the weight is a big deal. Explain why to the patient. Why do you need to weigh every day? Some patients really need to know why because they don't want to do it or they haven't done it for all these years of their life. That if you explain it to them, maybe they're motivated to weigh themselves. So what I say to the patient is, I know how to help you stay out of the hospital. And since they were just in the hospital, their ears perk up and they go, "You do?" I said, "Yes. If you weigh yourself every day, you'll know what's happening." So this patient was admitted at 168, discharged at 150, and little by little his weight is going up. And if you see that, you can tell them if it goes back up to 168, he'll be back in the hospital. If he knows who to call, someone can intervene, one of his providers. So the weighing is a trick of the trade. So if you can explain why, it really helps them. Low sodium diet. We don't like to tell 80-year-olds and 90-year-olds they can't. We like to ask them, what do you like to eat? So when you are talking to them, you can have these little conversations and say, who does the grocery shopping for you? Well, that person needs to be educated then too on how to read a label. I mean, your dietitians will meet with your patients, but you can find out who does the grocery shopping. What do they like to eat? Do they eat out? And we explain to patients, we have some education on choosing foods that are lower in salt when you go out. It's not that we're saying no, no, and no. We're just giving them tips. And so there's tips on, talking to the chef at the restaurant and asking him for a lean meat, baked potato, and a vegetable without salt. Well, that's better than saying don't go out to eat. But I do tell him what Dr. Katroser says. It's one of our cardiologists. He says, number 1, no fast food. Number 2, no fast food. Number 3, no fast food. I mean, almost every fast food is 2,000 milligrams in a sandwich, in a whatever. It's just very high. But we do have a patient who has his own table at McDonald's, and he has found a couple items that are, like 480 milligrams. So I think it's just part of his social life. So he's made it work. Medications. When you give the lisinopril and the carvedilol, open up this book under medications, page 9, and read what lisinopril and carvedilol do. They're life-saving medicines, and if you explain why you're giving that to them, maybe they'll be motivated to take it. Maybe they'll have hope that they can get better, or at least prevent their heart from getting weaker. Symptoms, by looking at that stoplight every day, you will review symptoms, their heart failure symptoms. Again, they'll probably come to you in the yellow Hopefully when they leave, it'll be in the green, and remind them about the putting it on their refrigerator. Key reminders: daily weight, low salt diet. You can tell them if you eat less salt, you retain less fluid. It's that basic. And it's all about hidden salt. If they can omit the salt shaker, that helps. But it's really, we're talking about hidden salt. It's hidden in so many things. Again, it takes a team to take care of these patients. It really does. It takes the hospital folks, the TCU. You're really in a great opportunity to teach patients a few things, make a difference for them. Refer them to the core clinic. Their family members, home health are important, team members, and their primary care doctors. Again, daily weight and the stoplight form and who to call is the key. In the hospital, the hospitalist may have ordered a core consult, which was the beginning of the enrollment. So then the core nurses review the patient, and if they have never seen a cardiologist, they will have that appointment first after their stay here. And then they will come see us in the core clinic, the nurse practitioners. So that's why I mentioned if you see a patient and you talk about the core clinic, they may not know what that even means or is. So that's generally how the process will go. If you see that they're not labeled core, that they weren't enrolled in the hospital, but you have seen that they have had many readmissions, you can bring that up to the provider here and say, I can see that they need some education. Maybe it would be beneficial for them to be referred to the core clinic. And the way that works then is we generally talk to their primary care doctor and ask them if they'd like to work together. Okay, well, thank you.
Thank